Good afternoon, everyone. I am so thrilled to be able to present today on counter trafficking and health. And in addition to the World Day Against Trafficking in Persons, today is also the International Day of Friendship. So two things to celebrate today. So as Roz mentioned, I'm an emergency medicine physician, so I come at this very much from the medical and the healthcare perspective. And I'm really excited about this opportunity to talk about that intersection of health and trafficking. The health sector is often kind of overlooked and ignored as a really important ally and champion in fighting trafficking. So we're going to start off with a case here. So as we go along, I encourage you to read the slides and think about it for those health professionals that are listening in, and even those that aren't health professionals. Just imagine Pedro in front of you. So he comes in through the emergency department, and we have a part of our emergency department where somebody's initially kind of screened by a nurse, and a basic story is obtained, and their basic vital signs are obtained, and a brief physical exam. So he comes in through that part of our emergency department, and he's accompanied by his friend Martin. And Martin says, Pedro got injured on the job. We just need to get him checked out. Let's get him some pain medication so he can get back to work tonight. And Martin says that he needs to stay with him because, Pedro doesn't speak English very well, and Martin's there to help out with interpretive services. One thing that's noted as registration is done is that Pedro doesn't have any identification, and Martin apologizes. He says, I forgot to bring it. It doesn't matter because he's new here anyway. He doesn't have any insurance, and, it's not a big deal. We'll just pay cash for his care. And that brief assessment that's done by the nurse, so that screening assessment, shows that Pedro is pale, that he's ill appearing, and that there's bruising on his arms when she goes to take his blood pressure. The nurse also notices that Pedro's not really speaking spontaneously, even whenever an interpreter is used. And he's really not making any sort of eye contact with those around him. And most of the questions that are posed directly to Pedro are answered by Martin. And when he is asked to answer questions directly using his native language, he just kind of speaks some quick syllables, a couple quick words, and then looks right up at Martin afterwards, after answering any questions, if he does answer any questions. So it's not a surprise. This is a case of human trafficking. You're here listening to a webinar on human trafficking, and I have this scenario, this case that I present is really chock full of some concerning features. So having heard that story, I want you to pause and think of what pieces would be concerning to you just in general, as a clinician, as a citizen. What are the pieces that aren't really adding up? And here I've highlighted some of them here. So Pedro is accompanied by a friend, Martin, and a lot of times when somebody accompanies another individual to the healthcare setting, when they're there, they usually have their best interest in mind. They're there because they're taking time out of their day, and they're worried about the person that they come in with, and they're worried about their health and their well-being. And the relationship here clearly shows that's not what we're seeing. It's also interesting that his focus doesn't seem to be as much on getting the care that he needs, but getting pain medication, getting him back to work. He was injured on the job, which is noted here, and then this insistence upon staying at the other individual's side. So Martin refuses really to leave Pedro's side. Another red flag that we see here is that Pedro had no identification, that he's new to the area. And some other things are his actual medical status. So here's a construction worker, and yet he seems frail. He seems malnourished. And usually when you think about the ideal kind of person that might be working in a construction site, they should be healthy and strong. And that doesn't make sense. And then I could also highlight here too the fact that there's bruising on his arms. We were trained as clinicians to notice bruising that doesn't add up to the story, that is indicative of trauma over time. And those pieces are here that are kind of stigmata of abuse. He's not speaking spontaneously. So the communication pattern in general really shows that Martin is in control, that Martin has power in this relationship. And it's the loudness of the nonverbal cues here that are concerning. So again, the surprise here is not that this is a case of trafficking, as you know, that's what we were going to be talking about today. But what I want you to do is, as you're listening to all that I have to share today, is that you think about patients just like Pedro, where things aren't adding up right, that there are signs of abuse. And in addition to all of the other things that you might think of that could be going on, that you add human trafficking to your differential diagnosis, or you add human trafficking to the list of things that could be going on when you notice that things are off, that there are these red flags. So today we're going to be talking through some of these questions, and my goal is that we're able to answer all of these questions by the end of our time together. So why is the health sector such an important partner in counter-trafficking work? Do victims of trafficking come into contact with health systems? How does the trafficking situation impact a person's health? And what can health providers do in the fight against trafficking in persons? This first diagram I have here is how I started to really understand human trafficking the more that I understood what was truly going on with trafficking. And it actually all started with, at my own hospital, we were developing a protocol for trafficking. And I realized that while I initially thought, oh, this human trafficking protocol is going to be this siloed out, very separate protocol, so different from all of the other things that we do, I very quickly began to realize how interrelated trafficking was to these other forms of interpersonal violence that we are trained in dealing with, and that we have systems of response for. And this intersectionality really plays out on a lot of different levels. The more that I've learned about trafficking, the more that I understand that these forms of violence can be happening at the same time in an individual's life, that they may be happening throughout somebody's life course, that we can build on the systems response that we have from these other forms of violence. We can build on the research that we have from these other forms of violence and abuse to help inform how we care for trafficking survivors. And also it comes down to labels too, where I've never had a patient yet come in and say, hey, I'm being trafficked, but rather my patients themselves will use these other labels to describe something that once we scratch beneath the surface, we discover that trafficking is also going on. So I had a patient who would come in frequently to our emergency department and end up in our intensive care unit with diabetic shock. And she wasn't taking her insulin. And she had initially been labeled as kind of like a frequent flyer. Why is this person coming back and not taking her medications? And it took a nurse who really built a relationship of trust with this patient for the patient to feel safe and comfortable opening up. And the patient then said, you know, my partner's hurting me. Her partner was physically and emotionally abusing her. And then she opened up a little bit further, and there also was an element of commercial sexual exploitation that was going on. And so this patient that had been labeled otherwise ended up being a victim not only of human trafficking, but intimate partner violence, but had labeled her experience primarily as intimate partner violence. So what is trafficking? Just to briefly go over that definition. So trafficking is defined in terms of the trafficker, which is the opposite of how I typically, as a clinician, I think about my patient, I think about the victim at the end of the day, but this is the way that the laws are designed in terms of the criminal laws. And so this model that we see as laid out from the Palermo definition from the UN is divided into these categories of action, means, and purpose. And then again, this is all in on the part of the trafficker. So the trafficker may recruit, may harbor, may transport, may provide, obtain by any of these means. So it does not have to be force, fraud, and coercion. It can be any of these mechanisms for the purposes of sexual exploitation or labor exploitation. And then there are other types of exploitation, including organ trafficking, that are laid out by the UN Palermo Protocol. And we're going to get into this in a little bit more detail because it's directly related to the health consequences and mental health consequences of trafficking. traffickers use any and all of these means. They use physical and sexual violence, fraud, so bait and switch offers where someone is promised one thing and then whenever they arrive to a place, they discover that the terms are different and they're stuck. And coercion, so not only threats against the individual themselves, but against their family. These next few slides I have in here because the moment you heard the word trafficking and you knew you were going to be coming to this webinar, you probably had an image in your mind of what a trafficking victim looked like. And that image is informed by media, by different information sources that you've taken in, whether it be a movie, whether it be a news article that you saw online. And a lot of times the portrayals of trafficking that we see in the news are kind of, they will fit one demography. In the United States, a lot of those are a white girl from Europe. And so these next few slides are just, they're not trafficking victims, but they're just to start that process of helping you to think about the fact that trafficking victims can affect, or trafficking can really affect any person of any race, any sexual orientation, any ethnicity. So just to keep your mind open and realize that we all come to this with our own stereotypes. Trafficking occurs in industries that are underregulated and underpaid. So you can imagine that's a lot of different industries. It could be domestic servitude, somebody working in a wealthy diplomat home as a nanny, as a house cleaner, providing elder care, construction work, as we saw in the case of Pedro, agriculture, dry cleaning. So these are just some examples. Nail salons, we see examples of women who are trafficked for sex at night and for labor during the day. I'm asked very frequently, how does someone end up being trafficked? And there are so many different pathways by which somebody may be exploited. And so I don't have enough time even in this one presentation to dive into all those different paths. But we in this day and age, we're seeing epic proportions of migration, and people migrate for a variety of reasons, whether it be in search of a better life or being pushed from their home countries by violence, humanitarian crises, or natural disasters. And the reality is that when someone is migrating and on the move, if we think about this dad here with this child, all of those traditional supports that they had back in their home community, social networks, occupation, housing, all of these different pieces that they typically have in place are stripped from them when they're on the move. And so somebody that's migrating really is at increased risk for being trafficked. And agents for traffickers use a variety of means to coerce them. But how does this dad here, who may be fleeing a violent community in his home country, how does he know and distinguish between somebody who's offering him a real job and somebody who's offering him a job that will end in his exploitation and his family's exploitation? Another trend that we're seeing here in the United States is links to drug use, in particular the opioid epidemic, where traffickers will recruit their victims directly from places that are supposed to be addiction treatment centers, such as methadone clinics or detox centers. And there have been a few of these cases, some of which have been civilly and some of them have been criminally tried. There was one case of a woman with cognitive disabilities who was held in forced labor, and her traffickers would beat her, take her to the hospital or clinic, and then obtain opioids as a way of not only keeping her in check, but also as a way of obtaining opioids for their use. We've also seen manipulation of the very system which is meant to rehabilitate those that have an addiction, where a court may say, instead of going to jail, you need to do this rehabilitation process, and that rehabilitation process is linked to a trafficking ring. And this is a case of one that was in a chicken plant on the Arkansas and Oklahoma border, where they were forced to collect dead chickens and throw them into a heap of rotting carcasses. Another defendant worked 12-hour days stacking pet food and was in so much pain he could barely use his hands. Other men hung live chickens on shackles as bird feces flew in their mouth. So traffickers use any and all means to keep their victims in check, and so often these are not things that we can see with our own eyes. So, a lot, again, going back to kind of the medial portrayal and maybe some of your own stereotypes around trafficking, you may think that this involves, somebody that's in a cage or being chained up, but traffickers use very powerful psychological coercion and don't even sometimes have to use physical force and keep their victims in a virtual mental prison. This wheel just kind of demonstrates that further. It was adapted from the Wheel of Power and Control from Intimate Partner Violence to just show all these different ways that traffickers use to keep their victims in check. Traffickers manipulate the basic needs of survivors in order to keep them in check. And here's the Maslow hierarchy of needs pyramid, knowing that just depriving somebody of sleep can be very, very powerful. Depriving them of food or controlling the ways in which they get food, the ways in which they get health care. This example, I just have this picture to remind me that this one trafficker would go out to a fast food restaurant in the Boston area and buy a number of fast food meals and put them in the middle of the floor and force 30 women to fight over each other in order to get just a morsel of that food. So even in the very act of getting nutrition, which they couldn't control at all, they were also just treated like animals, that they were objectified and denigrated in that way. We see over and over again that trafficking survivors are also given this kind of elusive price of freedom. These are actual court documents from a case out of Florida where a trafficker had set a certain amount that if you bring this much back, you will, if you net this amount of money, then you'll be free. And of course, the system is rigged against them. So in this case, the woman even had to subtract shower water from her tally. And we see traffickers that have these schemes where a bar of soap is $20, where rent in a trailer that has a leaking roof and no running water is $3,000 a month. So again, this system that's rigged against them. So until really the last 5-10 years, we've really, given that traffickers keep their victims in check in so many different ways using force, fraud, and coercion, it really wasn't until the last 5 years or so that we have known that the trafficking victims access healthcare during their exploitation. And granted, a lot of these studies do come from developed world contexts, but the more that we're learning from around the globe, the more that we're seeing this to ring true around the globe. And so this is a study from my colleague McKinney Chisholm Straker, where she looked at both those that had been trafficked for labor and for sex, and asked them, when you were being trafficked, did you access healthcare at any point? And 68%, so well over a majority of those trafficking survivors had accessed healthcare during that time. And then she asked the next layer of questions. So, which types of health professionals did you see? And the number one here, not surprisingly, it was emergency departments and urgent care settings and primary care, dentistry, and OBGYNs. This percentage here is very similar to one from the UK as well. This pediatrician one is very, very low to me, just given the definition of trafficking in the United States. So again, we're constantly learning, and there's more research to be done. And then we're seeing a number of patients that are identified in our psychiatric clinics, inpatient psychiatric care, as well as outpatient, those that are in substance use treatment centers. And so this is just a tip of the iceberg in terms of understanding which types of health professionals. What this means to me, this 68%, is that healthcare has this huge opportunity and responsibility to be equipped to respond to trafficking, to have the tools in place if that victim comes through our doors, that we need to have the plans in place to be able to not only identify them, but to connect them with the resources that they need. And who better to do that than a health professional? Health professionals are largely trusted individuals, unlike so many of the individuals that victim may come in contact where they really wouldn't trust a police officer, and they wouldn't trust a business owner, but they might trust a nurse or a doctor. So I really do see that as our opportunity and responsibility. So this breakdown I really like. It's from the Caring for Trafficked Persons, which Roz was a part of writing, and is a great resource. So how do we identify somebody that's being trafficked? And there are many things in health where we can use formulas, we can use quick diagnostic tests to figure out exactly what's going on. Trafficking is not quite like that, but it's very similar to how we recognize abuse in general. So it's the way that I break it down is thinking about these two buckets of the health things that are going on and the context piece. And you can think back to Pedro's case, his health needs. So, he was malnourished, which didn't really fit with the fact that he was a construction worker. There were also signs of trauma over time on his body. And the contextual pieces. So he was accompanied by a minder. So he came in with somebody that really didn't want to leave his side. And he didn't really know exactly where he was. So those may be some indications that somebody is being trafficked, just as they are maybe indications for other forms of abuse. We also see that somebody may present really late with something that should be pretty simple. So sorry if feet are gross to folks. It's a pretty disgusting picture, but so there was a case of somebody that just had a simple ingrown toenail, but that went untreated for years because they were not unable to access healthcare for a long period of time. And finally, her trafficker in this case allowed her to see a doctor. And at that time, the condition was so bad that she needed to have surgery to remove the ingrown toenails. And if she had waited any longer, she might have lost her toes. And so this is an example where, a trafficker, unfortunately, the way that they see their victims is completely as a commodity. And so if they're unable to work at a certain point, that may be the tipping point that allows them to see healthcare. And so a health professional may see somebody after things are pretty far along. One of the questions that we have all the time are what are the things that we would see? What are the main chief complaints? What are the main health problems that trafficking victims experience? And just as there are many ways and many journeys that lead to somebody to being trafficked, there are also many different sectors that people are being trafficked into. And so each and every one of those sectors and every piece of that journey affects what those end health outcomes or health consequences are going to be. So the way that I break it down in my own mind, and this is kind of like a public health way of breaking it down, is to think about exposures or things that an individual may be exposed to before their trafficking, during their trafficking, and after their trafficking that affects what health outcomes may be at play. And so, just looking at this picture here, somebody that's doing agriculture work for hours and hours in the sun may come in with sun poisoning. They may come in with pesticide exposure. So those are just a couple examples. Construction workers, as we saw with Pedro, came in with some injuries from falling off of scaffolding. And this is from a study that Roz and I were part of, where we looked at 3 different countries and 3 different sectors of trafficking and those that are labor exploited, and looked at those various conditions, whether it be before they ended up being trafficked, while they were being trafficked, and then out afterwards in terms of the consequences. And here's another wonderful table. I'm not going to go through any of these in detail, but just want to provide them here as a spark for you to explore further if you want to look up these resources. This is from that Caring for Trafficking Persons manual that we mentioned earlier, and then again breaks down the conditions that someone is exposed to, and then the outcomes, the potential health consequences. So I hope what I'm showing you here is that really there could be anything from head to toe that could be an indicator that somebody's being trafficked on their physical exam. And then it can also be things that are more related to the way that the body deals with abuse, that may present as something where they think it's a physical problem, but it's actually related to their mental trauma they've experienced. So chronic headaches, chronic abdominal pain, where there's not really any other reason for them medically to have these symptoms, but because of the psychological trauma they've experienced, they end up having chronic pain. So I'm going to share some more examples from the study that I mentioned earlier with that Roz and I were involved in with London School of Hygiene and Tropical Medicine, as well as some examples from a study here in the United States. And bring to life some of the exposures and health consequences from stories and quotes from survivors. So this is an example of survivors not being able to use personal protective equipment and then some medical problems that result from that. So personal protective equipment are those things that are that one should use on a job in order to minimize having an injury or having a health risk. And what we saw in our study is that there was a trend for those that were being more exploited and those being trafficked would not have access to their personal protective equipment. So those who are legally employed get a face mask, but while you work off the books, you don't get one. You have to buy it yourself. Or if not, you can make yourself one using a thin kind of fabric. So this is something that, you may guess like, oh, this might not be so bad. But the problem is that if somebody is working in a textile factory, as this individual was, there are specific masks that filter out the really bad particles that can get deep down in one's lungs and cause a lot of harm. And if you don't have the right mask, it might look okay, but it's actually not doing anything. So here's a schematic that helps me to think through, and I think is a beautiful example of thinking through all of these different pieces of exposures and how they can compound each other in terms of the outcomes of health problems. So you can imagine even if we take age here, if somebody is 10 years old and doing the same type of work in a factory versus somebody that was 50 years old, the way that their body experiences that and the health problems that will result from that are going to be different. I mentioned the personal protective equipment here, how many hours they're working. All of these different pieces play into what is going to result in their health consequences. So this is an example of that airborne exposure. So because most workshops have windows, because of the dust, if we absorb it, it gets into your bronchiolitis, it attacks the lungs and those things. I don't know what they call that disease, but it's caused by the dust in the lungs, coughing up, splitting up blood. I don't know what the disease is called. Where I live, there was a man next door in another room who spit up blood. That's contagious and it happens because of the dust in the workshop. So this is an example of the lack of personal protective equipment causing what could be a few things here. It could be silicosis, and then tuberculosis, and that would be then infectious. But the insidious day in and day out exposure to those particles in the air and not having access to personal protective equipment really can have a profound effect, and this person may end up even dying from that underlying illness. Environmental exposure. So there were dogs and cats. The dogs were sick and I had a rash that I could not stand stinging. There was something of a dog disease and I'm not used to being with many dogs. And this dog had scabies and he jumped on me. They didn't take me to the doctor. No, I was cooking and I could no longer endure the itchiness. So not just what's involved in the work, but what is the environment like? Where is that person living? Where is that person eating? And what is around? You see that traffickers use physical isolation. The security head said, "If I find out you're hiding something from me, you will end up badly," started threatening. "Accept it." I said, "Okay, I know nothing." I was asked to run, but I refused. If I wanted, I would run, but where would I go without documents? So I stay. So this gives you a sense of the not even needing to use physical violence, but the threats and then the lack of documents being really profound in terms of keeping someone in that location. Here's an example of violence. The employer threatened not me personally, but all of us, frightened, saying, "Do not try to escape. We'll find everyone." As we were working, 30 people escaped the construction site. He found 20 and brought them back. They fled without passports. He beat them with his assistants. He said to them, "Do not try to escape. We will find everyone. We have enough power in Almaty." But no one escaped. He gave no money. While there was a guy beaten, I didn't see, but I was told so. So here's that threat, and that also the stories that can keep somebody in check. This guy refused to work and he said he was going back home. He was beaten for this. If a man worked, he was not bothered usually. Those who were not working were bothered. So the avoidance of the violence too is a powerful effect. So given all of these physical exposures, that the physical consequences of trafficking are pernicious and pervasive. But to be honest, the mental health consequences of trafficking far, if I had to give a quantity to it, far outweigh in terms of longitudinal effects. So, you can treat someone's sexually transmitted infection. You can treat someone's broken bones. but the psychological impact of day in and day out of psychological manipulation is just really, really powerful, and and is an invisible scar that sticks with people for the rest of their lives. So here's a quote from a survivor: "I felt like nothing could make it better. I felt like it was only a piece of meat with two eyes. I thought it would end up like nothing. There is no hope for me." So from one UK study, we see these percentages of physical violence, and even women who are labor trafficked are more likely to experience sexual violence, and they remained afraid of their traffickers even after they were out of their situation. So this study, I don't have the citation at the bottom, but I'm happy to provide it, is a study by Elise Hopper, where she looked at some of the mental health consequences of sex and labor trafficking. And again, I think it's a natural inclination to imagine that the PTSD from sex trafficking is powerful and horrible, but labor trafficking victims also experience really high degrees of physical and sexual abuse, and therefore PTSD. And what was really interesting from the study as well is that if somebody had a prior experience of child abuse before they were being trafficked, that their PTSD symptoms were higher afterwards. And you see here, and again, I point out the labor trafficking because it's, you would imagine, I think it's human nature to imagine that the mental health consequences might be greater for sex trafficking. But here, just look at suicidal ideation, that sex trafficking in this study was 47%, and then in labor trafficking was 43%. And we need to understand each of these things further. We need more studies with greater amounts, because you see here that the sample size is 30, but I still think it's helpful information. And then this gets to some of those things I was talking about earlier in terms of the chronic symptoms that may or may not be from a medical cause. These are some of the PTSD symptoms. So we see that recurrent thoughts and memories of the most hurtful or terrifying events, recurrent nightmares, feeling as though the event is happening again, sudden emotional or physical reaction when reminded of the most hurtful or traumatic events, trouble sleeping, feeling jumpy, easily startled. So I'm going to switch gears here a little bit. So we've gone over some of the physical and mental health consequences of trafficking. And this next section is to get us started in thinking about how we should identify trafficking victims. And before we dive into that, I just want to say a brief word about how we all in our minds have a perfect victim. We have in our minds not only, what a human trafficking survivor might look like, but also those individuals that melt our hearts and make us want to take care of them. And in my experience as an emergency medicine doctor, what I've realized is that most of the trafficking victims that I've identified in my emergency departments are the patients that actually make me angry. They're, as I mentioned, we're seeing lots of links with the opioid epidemic. So they may be somebody that's using substances and is mean and aggressive. And then just a result of the trauma they've experienced, they defy the typical stereotype that we all have in our minds in terms of who a perfect victim might be. And so part of the work of identifying a trafficking victim is knowing the red flags and all of these different things. But part of the work is also identifying our own unconscious biases, our own implicit biases, and realizing that trafficking victims, as part of the way that they're surviving each and every day, may not fit our profile of what we think of as a perfect victim. And this is just another example of that. But like on the left here, we see a cat that like looks sweet and one we would want to cuddle with, and we know that trauma does sometimes cause dissociation in somebody that is very kind of calm and meek. But we also know that the way that trauma works can also create aggression and agitation. And again, that's a way that somebody may be surviving. So the way that we approach somebody that's a potential victim of human trafficking, of course, is not like this. This is from a show that I really liked, SVU. But this is an example of an interrogation. And the reason I have this here is this is what I see where one of my trainees, one of the students I'm working with, is really concerned that somebody might be trafficked. And so they're so concerned that they go into this other mode where they're like trying to get the story out of somebody without realizing that they're shutting them down, without realizing that what they've done is turned into an interrogation. So the key is really that body language is more important, and the environment you're creating for disclosure is more important than any of the words that you might use. And it's not about rescue. So that the individual in front of you may maybe not be at a place that they are ready to leave that situation. The key tenets here are to prioritize safety of your staff as well as the individual. Try to find a way to talk to that person alone. In my emergency department, we can try to get a urine, pretend that we're going to get a urine sample from somebody and walk them to a bathroom around the corner as a way of not raising any alarm bells and getting that person alone. Using an interpreter, being trauma informed, so realizing that all of our patients may have experienced some sort of abuse, and so at every opportunity where we can allow for the patient to have choice and control, to allow that. I put these questions here. They're derived from the Vera Institute tool, and they're currently in the process of being validated. So these are not validated yet. So that is the big caveat before I put these up. But I do think it's important to have some words and to start trying to ask some of these questions for those of you who are clinicians of your patients. So here are some potential screening questions. Have you ever worked or done other things in a place that made you feel scared or unsafe? Have you ever been tricked or forced into doing any kind of work that you did not want to do? Have you ever been afraid to leave or quit a work situation due to fears of violence or threats of harm to yourself or your family? Has someone you work for ever controlled the money you earned or kept money you earned in exchange for transportation, food, or rent without your consent? Have you ever received anything in exchange for sex, a place to stay, gifts, or food? So if you're at that point where an individual in front of you is, you're pretty sure that they may be trafficked, what are the next steps? So I pause here to say that my hope is that you will have a protocol in place that you can call upon, whether it be you or one of your colleagues who has this person in front of them that is a potential survivor of trafficking, that as a result of this presentation, you go back and you create a protocol. So there's not a question of, oh gosh, what do I do next? It's okay, where do I find the plan? I put this link here. This is a link to the Heal Trafficking website, and this protocol toolkit, which is a toolkit, a manual for developing a protocol in health systems from A to Z, all the way to monitoring and evaluation, is free to download. So I encourage you to go to our website and download that. It's been downloaded over 1,800 times in over 24 countries. So we're definitely seeing a hunger for this tool. I'm going to talk you through what we do in my context, and this is going to vary based on your local mandated reporting requirements, etc. So under the age of 18, what we do is involve Child Protective Services, and that activates a multidisciplinary team response. For an adult, it's building trust, not doing harm, not rescuing, and really finding out what the person needs and what they say that they want and need. So that may be, for some of my patients, that's a turkey sandwich. For some of them, it's trying to get them shelter, which is often hard because we don't have enough shelter beds. But it's really putting the power and control in their hands, because if you think about it, the trafficker's been controlling every inch of their lives, and we don't want to be another controller or victimizer in their life. This is an example of a general framework that we have in the Boston area for identifying and responding to trafficking, and this is available also on our website for free if you just want like kind of a framework to start from. So in just a second, I'll open it up to questions. I encourage you all to go to our website and sign up for our listserv. We share resources that are going in terms of activities and webinars, as well as research studies. All of that is shared on our listserv, and then our website serves as a compendium of a lot of the resources for health professionals on trafficking, all again open access and easily accessible for you, so you don't have to reinvent the wheel. We have committees that are working on each of these areas: education and training, protocol development, advocacy, direct services, and research. So if you want to get more involved in any of these specific intersections of health and trafficking, I encourage you to to join us. Again, the website is healtrafficking.org. So I'm so excited that I had this opportunity to chat with you all today. And I hope that as a result, not only in your individual practice will you start to think about the patients that you're seeing that might be trafficking victims and how you could possibly plug them into care, but more importantly, to think about the systems that you're in, and that each and every one of you will become a champion in your systems for creating a response, for creating a protocol, so that when the next trafficking victim walks through your doors, that they'll be identified and get the care that they need. So I will stop there and I will take questions. I think we just have a few minutes.
Thank you, honey. Thank you so much. And I will try to moderate a bit the questions. So we had a first question regarding one of the studies that you did not cite on the slide. I believe the question is regarding the mental health study. If you could repeat that information so our
yeah,
that study.
Let me go back to that.
And at the same time, there was a question about whether the slides will be available. And yes, we will put them on the CMC site. And we will also have this webinar that we recorded on.
Let me see if I can get to the chat box myself too, because I can type the last name of the author. I can find the citation for you, but Elise Hopper did this study where she looked at not only the mental health consequences of sex and labor trafficking, but also whether they had prior experience of child abuse. So Elise Hopper, ELISEHOPPER, did that study. And then, yes, we'll provide the slides.
So if anyone else would like to ask a question, let us know. Or let me see here. There is a question. Will you be doing a training on how to use the ICD-10 codes now that this basic information? So this is a reference to the changing situation in the U.S. Perhaps you can orient us in case some of us are not based in the U.S. as well.
Yeah, so to update people on that. So diagnostic codes are a system of categorizing a medical chart, both for data collection reasons as well as for billing purposes around the globe. And the WHO has a set of these diagnostic codes, and then each country also has their own set, and sometimes those ones are updated before the international ones. So we're at a stage in the United States where, as of October 1st, our code set for all health conditions, we're talking about pneumonia, broken femur. Now we'll have a code for human trafficking, just like we have a code for intimate partner violence and sexual assault. And that will be as of October 1st. And we meaning Heal Trafficking, is working closely with other collaborators to help create guidance for health professionals on the best ways of utilizing those codes. It is a balance of both, a desire to have more data collection to be able to describe the scope and risk factors and resilience factors for trafficking victims that access healthcare, and balancing that with privacy concerns as well as safety concerns, knowing that in many of our health systems, we have electronic health records, and in many of the electronic health records, there are patient portal access points. And we know from intimate partner violence and from trafficking as well, that the controller may have access to any number of passwords in a person's life as a way of controlling them, including potentially their access to their medical record. And so how do we make sure that we're balancing both of those considerations in terms of data collection as well as privacy and safety of the patient? So look forward to inviting all of you to those conversations.
Thank you. I have another question for you. Can you tell us a bit more about your experience with why or how you can create a situation so ask for help, and why, and what we've learned so far about why our survivors disclose their need for help or their trafficking situation and why they don't? Because I know there's been some studies about that.
Yeah, that's a great question. So the way that I think about that piece of how do we create the best environment for disclosure is understanding, first of all, reasons that sort of provider side reasons and then patient side reasons why a disclosure may not happen. So on a patient side of things, I may see an individual in front of me, and they may or may not even be accompanied by someone, but they may have been told and brainwashed, and told that if you tell anyone, I'm going to, and threaten, if you tell anyone I have your child outside here, and I'm going to do harm to your child or harm to your family. And so many trafficking survivors have told me that even before they're allowed to go to healthcare, that they rehearse exactly what they're going to say in regard to whatever prompts that are anticipated, whatever statements or questions might be asked on the from the health provider side of things. And they're told if they deviate from that script that X, Y, or Z could potentially happen. So that fear, there's a great deal of fear that survivor or victim may have on their side of things. And I, as the health professional, that's invisible to my eyes, right? But I can also pick up on the nonverbal side of things. The fear also may come from fear of arrest or deportation. So many trafficking survivors, and we're working on changing this, but right now, many of them have been forced to commit crimes as part of their exploitation, and in many places that those crimes are still on their record. And so if you call law enforcement, that could result in them being arrested, and the trafficker may have reinforced that concept with them. And then many of them fear deportation as well, which is a very real fear, especially right now. So that's kind of on the patient side of things. And then on the provider side of things, those are the things that I can really control. And we know from looking at some studies, as well as I can just add from talking to survivors, that number one is the feeling judged by a health professional. And that can come across in a number of different ways, but many survivors, especially sex trafficking survivors from the studies that I'm thinking of, a study by Kathy Miller, for example, showed that many of the victims of trafficking felt judged by their health professional. So you can imagine if you're feeling judged, you're not going to open up in any way. And then beyond that, it comes down to basic communication, finding a moment alone with between a health professional and their patient. That should happen for so many reasons, right? That should happen for conversations around sexually transmitted infections, for other screenings, for other forms of abuse. And I really do believe that every patient deserves to have that moment alone with their health professional, health provider, and being eye level, showing that you care. Survivors of trauma really do have high sensitivity to know whether the person in front of them is just checking a box or whether they actually care. And you may not feel that that's obvious, but it really does show. So going back to just the basics of communication and basics of human interaction, but also realizing that individual, today may not be the day that they disclose, and the goal is not disclosure, but that you have shown them human kindness such that the next time that they come to a healthcare setting and may come back to your health setting, that they know that it's a safe place. So you don't know when you're screening for trafficking whether you're it may take 100 times of interacting with caring individuals till somebody opens up and shares what's going on. And you don't know if you're at the beginning of that journey, whether you're the first person or whether you're the 99th or 100th. But each of those interactions matters.
Thank you, Hani. Thank you so much. I'm not sure, unless someone else would like to ask a question, I think we'd like to thank you for taking time out of your busy schedule to share all of these thoughts. There's so much here we could speak about for quite a long time, but we have just...
Thank you.
Thank you for your time, and thanks to all our participants. And we will put the webinar and the materials on the CNC website. Thank you so much. Yeah. And there's information about the CMC platform if anyone needs it in the chat. Thank you.